So we have no disclosures and conflict of interest. Only idea is to know what ethics, how we practice ECMO day-to-day basis. Now, the goals are mainly because of just to ensure the patient best interest, the autonomy of the patients, informed consent, shared decision making, surrogate decision making, and end of life care. So these are the 6 headings where we have to keep in mind when we discuss something about ethics. And the principle of ethics, it has 4 components, like beneficence comes first, that is the good of the patient comes first. Non-maleficence, do no harm. Autonomy, patients have right to choose and refuse treatment. And the justice, where the scarce resources should be distributed fairly. Now, a lot of issues are on the top of that we are facing day-to-day basis regarding DNR, but ECMO is acceptable, CPR acceptable, but not ECMO, do not intubate, but ECOR acceptable, do not ECMO orders, and moral distress. Now, I will start with a case, few cases, and we'll ask our esteemed panelists how we should proceed regarding these ethical dilemmas. This is a case of 48-year-old male post-transplant COVID ARDS on ventilator, where PCO2 is recorded more than 140 and pH is 6.8 on triple vasopressors, and obviously we got a retrieval call from 100-kilometer distance, and there is one episode of bradycardia which happened and responded to adrenaline purge. Now on arrival, pupils are dilated and not reacting. My question to Vivek sir, how we are going to proceed? Are we going to put the patient on ECMO or not?
Okay. Good morning all. So this is a challenge most of the time we come across when we are planning to initiate ECMO. So many times it happens because these patients are usually critically ill and they are already on the high vasopressors and they may have a bradycardia or sudden cardiac arrest, and this is what exactly happened in this case. That we have got a retrieval call and we have gone all the way, and PCO2 was high and patient had a sudden bradycardia, though just responded to a adrenaline purge. And when examined, the pupils were bilaterally dilated. So if the patient is hypoxemic, which we can see with the PO2 level of 44, it's quite common that there is a pupillary dilatation in a short span of time of hypoxemia. And moreover, PCO2 is also high, so quite likely the bilaterally dilated pupil cannot be a good indicator that we should avoid doing the ECMO in these patients. But what is important here, that a patient relative should be counseled thoroughly, and an appropriate consent must be taken in this situation, because you don't have a time to do a CT scan or to evaluate doing any imaging in these patient is already collapsing. And so I will go for ECMO in this patient because otherwise patient is looking at that short episode of bradycardia. So I'll go for ECMO in these patients.
Any input, Dr. Kapil?
I agree with the Vivek sir. Here definitely it is a challenging case, and with thorough counseling and written consents. And forget about the ECMO also. Even such patients comes to us ICU. First we have to think, should we resuscitate? Definitely we are going to resuscitate such patient. And definitely imaging will be not possible in such scenarios. But we should go all out looking at the age, and it is a very short brief period. So I am agree with the Vivek sir. We should go ahead with the ECMO support with due consent and thorough inform to a family and counseling.
So in this case, actually, it happens with the uncertainty. And uncertainty has probability, ambiguity, and complexity. And there is a 20% benefit, probability benefit of the treatment, rest of the things, ambiguity and the complexity. And so what should we do? That we are open to moral blame, but we should do what should be done for the best of the patient interest. And beneficence plays the main role here as an ethical uh, take. So case number 2 is a 11-month-old septic myocarditis with pneumonia. She's on 21 days of ECMO and she's not improving, but child is playful. Her CFTR gene came positive on day 21. Now, as 3 weeks has gone, we need to change the oxygenator. But parents do not want to continue further because the cystic fibrosis in the 11-month-old baby has not a very good prognosis. But the child is absolutely fine except the lung. Dr. Jayanti Kishore, can you have some idea how we are going to proceed with this patient?
Yeah, hi, sir. Actually, as you said, the child is fine. So I would be a bit reluctant to actually wean off ECMO, although the parents do not want to continue. What we can do is we can just counsel them, saying that it's although the prognosis is like bad, it's not certain that the patient will not make it. We can counsel them saying we can tide over the crisis somehow, pull off a little bit, try to change the oxygenator, use a custom-based circuit and change something, and you raise some crowdfunding and do whatever we can, and pull a little more for some more time and see what happens, rather than taking a decision at that point to withdraw. We can. I think the best thing would be to convince them to continue further for some more time.
Good morning, Arpan. Just a few comments from my side.
Yes.
It is about improving the awareness about cystic fibrosis in the first instance. Cystic fibrosis gene positivity is not like a death sentence. In the current era, the treatment of cystic fibrosis has improved significantly, and if everything is done, these patients tend to live up to their 5th decade also. So it is about staff education as well as with the parental education regarding this real change in management of this disease, and then if we instill hope into them, probably they will come forward with the plans to changing the oxygenator. So I will certainly persuade in changing the oxygenator, as Kishore said. So that would be my view, and this is not a situation to withdraw. Thank you.
Yeah. So what happens when this kind of things comes to us? Wait and see strategy we do, but on the side by side there is a moral distress to the nurses, because the child is playful and we are not going to give it up, but the parents doesn't want to go forward. So this is a very complex situation with interpersonal conflicts. There is a complicated grief also. So wait and see strategy sometimes takes time, and continuous counseling with the parent is key to continue discussion. Now, case number 3, where a 50-year-old male, this is a genuine dilemma, where a 50-year-old male severe COVID ARDS with PF ratio of 0.5 after 2 episodes of proning and 3 weeks of HFNC. Now shifted to our hospital. Only one ECMO CentriMag console is free. Other 21 machines are running. At the same time, 22-year-old amlodipine poisoning came to emergency after 18 hours of ingestion in shock. How we are?
Arpan, you had lost the contact. Whom you asked this question?
Dr. Dipanjan.
there are three choices that you have. That you have only one Centrimag backup and 21 machines running. So 21 patients are depending if any one of their machines have any problem, a power failure or anything like that, then this is the only console that you can shift that patient to. The second dilemma will be there are two patients who have come for ECMO. One is a 50-year-old male. He has been on HFNO for a prolonged period of time, for almost 3 weeks. And the other one is a younger male with amlodipine poisoning, where outcome can be a little bit better compared to the COVID ARDS patient. So whom are you going to give? First of all, choice is whether you say yes to ECMO to any patient or at all. If you say yes, then whom to give? So in my opinion, the choice will be for the younger patient who has a better chance of recovery with ECMO, rather than the 50-year-old male whom we can still try out with proning, and you can wait a little bit in a couple of days or in a day or two. If the one of the consoles in other patients are relieved of ECMO, then we can use it for that patient.
Vivek sir, any input?
Yeah, because this is the resource crisis situation which all of us have faced during the COVID situation. Because I will not prefer to put 21 patients' life at stake using the remaining one console. But yes, I'll find out if any nearby facility has the ECMO services available, or even we can place these patients on the roller pump if we have the cardiopulmonary bypass machine. That is another option we can have in this situation for amlodipine toxicity, because we know that ECMO will be a short run ECMO, and he is a relatively younger patient. Whereas the patient who is a COVID patient is still on HFNO, we still have an option of a non-invasive ventilation as well as the invasive ventilation to pull him to maintaining his saturation or gas exchanges. So I'll prefer to look for other facilities, because in the crisis management crisis situation, these management cannot go as a conventional one. So we should find out. In fact, this is a good question you have raised, that in a crisis situation, we should start developing a networking at the regional, or even should be a national level for those equipments or those procedures which are not routinely performed, and where there is a scarcity of the circuits or other equipment. So the first thing should be shifting this patient to the nearest facility if possible. Second, using a roller pump rather than using your one remaining console. And for the amlodipine toxicity, however, we can wait still for the other patient.
So, as we are all agreed with, there's a real scarcity, and as you have told, we should develop a chain network to get this availability of the machines, and particularly in recent scenarios of the oxygenators are not that available in every time. You might get into the situation again, even with the machines are in hand. So whom to give, whom not to give. In this scenario, we have obviously given the chance to the 18-year-old amlodipine poisoning, and that COVID patient we continue to ventilate and prone this thing. Surprisingly, the COVID patient actually did well without ECMO, and he recovered. And this lady we could not save because it's a late one, and the multiple organ failure has already set in, even on ECMO, so we could not save. But this is a genuine concern, and probably any kind of logistics issue can lead to this. We have to keep in mind. Now, this is a case where we all come across for the prolonged ECMO. It's a 62-year-old extensive COVID fibrosis in CT. put on VV ECMO for 140 days. Now, family is counseled for lung transplant since he was put on ECMO just 2 months, and they denied repeatedly. They don't want to go for lung transplant, but they are hoping that he will come out of ECMO. He's awake, alert, communicating, repeated for winning. Now, on day 140th, he landed up in septic shock. Now, family wants to go all out with VA ECMO support or whatever is possible for the betterment of him. Now, I'll ask Dr. Puvoni how we are going to proceed in this scenario.
In this situation, is the sepsis manageable or septic shock manageable or not manageable? That is one issue, because you already had 140 days on VV ECMO. If the septic shock can be managed, if it is milder or so, then that would be ideal situation. Otherwise, one need to consider family's request also to go on to VA support, explaining to them what will be the possibilities of coming off on VA support at that stage. But there is an intermediary way of managing these patients also, such as appropriate antibiotic therapy, management of septic shock, and using devices such as cytosorb, which might help. It is reasonably costly, but still intermediary devices like that should be able to help him to come off septic shock in this condition. So as far as possible, try to maintain without VA ECMO, but I don't think we can completely ignore family's request to go on to VA ECMO as well if we are not successful. Thank you.
Vivek sir, any comment on this?
Yeah, as rightly said by Dr. Puvoni, first we have to look for indication, because not all septic shock can be supported with the VA ECMO. You have to have a septic myocarditis. That's one. And second, as sir rightly said, that 140 days have passed, and we expect that this is possibly because of the circuit cannula, or most likely because of the circuit itself. So adding a cannula and placing, putting the patient on VA ECMO again may not be a good choice. So possibly the first angle is the clinical one, that we should see that whether it's really indicated or not, and that family should be counseled regarding that. Second aspect is the emotional aspect, because the family is attached emotionally, though they are not willing for transplant, but still they want to continue an ECMO. So they should be counseled in a manner that he may be benefited with other modalities where we can use cytosorb or auxiris or other filters, where we can sustain hemodynamics till the time antibiotics or other therapies are responding. Possibly VA ECMO may not be a good option in this situation. But this should be thoroughly counseled, and actually this should be a part of counseling beforehand only, when a family is refusing for getting a transplant done, that this is going to be a course in future, that gradually he may develop a sepsis, he may develop a multi-organ failure if we are continuing ECMO for a unlimited time. So probably if you have counseled it before, then possibly it will be easy at this stage to you to correlate with this that we have already discussed in the past, and possibly this is the option what we can offer. And anyway, you are not going for transplant and this is not going to recover. So at some point, we have to accept it and should give a best possible treatment. So the best option is the cytosorb or auxiris in this situation, rather than switching over to a VA.
So we have challenges like patient being aware of fact that impending death can be distressing and suffering. Family, there is a big emotionally challenging withdrawal. Health providers also come to play, because the patient is almost 5 months stress and the close ties with the prolonged stay. So these are the challenges. Obviously, the escalating to VA ECMO is going to do nothing, and to you have to have taken a intermediary step like escalating antibiotics or using cytosorb and in between what we have exactly done. So after 2 days he didn't make it, and we have not escalated to VA because it's a distributive shock. VA is not indicated here. But that was a very close, uh, uh, what should I say, this is a challenging case for the counseling and continuing the relatives because they were expecting till 140th day that he will come out of ECMO destination therapy. Now, this is case 5 where a post-LSCS COVID ARDS non-responder of Cronin, 29-year-old, for hospital. She is rescued on VV ECMO. As usual, the lungs ECMO, and she's nicely supported on VV, but lungs is completely wiped out. Now, the family was fine and they were ready to go with the patient, but they belong to a village where flood took away all houses and they have nothing to continue the treatment. They lost their valuables in that flood. Now, Venkat sir, how we are going to proceed this?
Sir, this is a difficult situation. The ball is not entirely in your court, and you cannot outrightly just deny the treatment, and therefore there has to be a hospital policy or a group policy to handle such situations. And when a patient, even if there was no flood in the village, then also there are patients who run out of resources, and then we tend to curtail the costly part of the treatment, so which in longer run proves more costly. So for such situations, there has to be a scale up or scale down mechanism, and there has to be some policy in the hospital if the hospital is taking ECMO as a program. So that policy can be to first reduce the charges from the hospital regarding the ICU charges. Second thing, the consultant can give up their consulting charges. Third, the medicine and other things can be sold as no profit, no loss basis. Then, of course, there can be call for inflows of funds through NGOs or through crowdfunding. So there are mechanisms, but again, it will not be very handy or very easily available at the time of the need. But then there has to be a backup mechanism where somebody is ready to absorb this financial shock and allow the patient to be on ECMO if the patient is improving.
Dr. Jayanti, how we are going to proceed with this patient?
So, as sir said, again, it's a multidisciplinary issue. We have to discuss with the management as well. But definitely, I would consider raising some funds for this kind of patient because he's a young patient. And I mean, we have done for a few patients like this, and we have pulled them out also. In fact, the families, I mean, it's not a 29-year-old, but I will tell a story of a month-old baby whom we saved like this. So the family was reluctant to take the baby back after putting back on ECMO. But luckily, baby went out intact with a normal CNS and everything. So the family was totally reluctant, but they didn't have funds also. They did not support, but we raised funds and we supported this baby and sent home. So definitely, with my experience, I can say that all young patients who have good organ function, we should not leave them. Somehow we have to do something and talk to people and convince the family and management and all that, and maybe reduce their bills, give more concessions on whatever we can do from our side.
Dr. Arpan, in
Yes.
the entire
Please.
cost, one second, in the entire cost of the treatment of ECMO, the consumable of ECMO is not even 10% of the total cost. The rest is the ICU cost and other antibiotics and other things. where there is a scope for margin and there is
Yeah.
a scope for reduction of the cost. So we just cannot say that the patient is not affording, so ECMO cannot run. ECMO cost is at the first initial days. Then there is no ECMO cost as such.
And moreover, these antibiotics and all those which are indented on IP basis cost almost double than what they cost when we get them on OPD basis. So I think we can do those kind of switchovers to reduce the cost.
Exactly. The way we have done in these pensions, like mostly the crowdfunding, there are consortium of ECMO survivors and their families. They have contributed counseling, obviously, these methods. But only concern in nowadays, probably all of us are facing, this crowdfunding, which was very much robust and very much fruitful during the COVID scenarios, are not that great nowadays. Because in our all experiences, like this patient also, I'll show you, almost the 50% or 60% payment came from the crowdfunding, and it was very robust. But now entitled for a crowdfunding, it's not getting amount of money or probably that kind of support where you can vouch for this kind of patient. So first thing, as I can say, that reducing the cost, the daily cost, reducing the consumables, reducing the cost of antibiotics, as Dr. Jayanti told, that you can ask for the patients to buy from outside with the reduced retailer costs, and this kind of things will be much more helpful. Because only depending on the crowdfunding is not going to, these are my recent experiences with 2-3 patients where crowdfunding has not supported much and the families are in difficult situations. But we could only swim through because we have reduced a cost substantially, probably as much as the crowdfunding can do by just analyzing where we can reassure our day-to-day expenditure. So this is the way we run our ECMO, and obviously all of us do the same. And for particularly the oxygenator, which we used to change by every 14 days, like the US FDA told us. But probably this is not needed with the regular oxygenator monitoring by torch test or by post-oxygenator ABGs or the pressure monitorings. You can jollibly continue the oxygenator till it expires. So in this patient, obviously we did, the patient was with us for 81 days on ECMO and only single oxygenator used, the first one, and that was fantastic, fantastically managed, and she came out and her hospital stay was 112 days with 81 days of ECMO. So we could come down on the cost by ourselves. That is the best thing we can do. And obviously the rest of the hospitals and the crowdfunding helped a lot. Now, case
Arpan,
number 6.
Arpan, before going to the next case, I'll just add on the problems that you said that the crowdfunding is not adequate. I'll add on one more point, that is, we are here all the clinicians. We are bound to the patient by duty, and we want the ECMO to run. But also to consider the present scenario, what the hospital management, are they with you? That is one of the major things that we have to ensure, that the hospital management is also on the same page in helping the patient out. That sometimes is not, if it is not there, then you are in a very big distress, both moral distress because you have to continue this patient on ECMO, and the secondly, every day you will be challenged by the hospital management to answer them why you are continuing without any financial reward or financial benefit to the hospital. That is a big thing that is there. The corporate hospital managements, they also need to be little bit sensitized to the needs of the patient, but that is not always there. That's a big issue that we are facing nowadays.
Exactly, exactly. That's why I'm telling you. Until unless you, myself or you or us reduce the cost, it is going to be extremely difficult because what happens, the management thinks this will continue next with all the patients. And sometimes it happens also because we are not afraid of the long ECMOs, but they are. And the people are they are very much fond of this 5, 5, 6, 7 days of ECMO, but actually it doesn't happen all the time. So it's a difficult journey, it's a tough journey, and we have to, from the day one, I think we have to probably you can't have the control on day one, but from day two probably you have to keep on reducing the cost, reducing the investigations, reducing the use of antibiotics, utmost infection control, and everything that will actually give you some economic relief. Otherwise, it is impossible to run an ECMO until unless you have this thing with more than 13, 14 days. And it's very much distressing for patients and you also. And the problem is when the patient is little bit of improving side and the relatives are devoid of money. That is the worst part of the game. There come the litigations and all these things. So it's a difficult thing. Everybody of us is managing things on our way, but this is going to come in everyone's life.
Arpan, just adding on to what Dipanjan said, like for those who are working in major corporate hospitals, if the corporate has had some sort of concessions from the government, they are under obligation to provide a percentage of their care as free care. So if the patient is really deserving, requesting for inclusion under that category would be a way forward as well. Major hospitals, like if they got the land free or if they got land at concessional fees, etc., they have to provide a percentage of their care free. Thank you.
So they are not interested in any free care for anyone now.
I heard they are under obligation because they are provided free land.
Yes, sir, they have the obligations, but I think they have forgotten those things. They don't do that. But
all charitable.
I should not 100% blame them because it is they who actually gives us some room also. But it is always when the outcome is good. Everybody relies on the good outcomes. The bad outcome is yours. Good outcome is everybody's. So
in this patient,
we have to balance that.
Now, this patient had survived, so you generated a goodwill which you can use as a marketing tool to get more patient.
Huge
goodwill. But
huge
had this
goodwill.
patient not survived, then that would also not be there. So it's a loss for the hospital.
Okay, coming to the last case where I think Dr. Puvoni told me to put this case to the audience. Just with the case. As the Monday after coming out from ESY workshop, you got a case of 6-year-old child with severe ARDS just joining back to your place. Now, as you have never cannulated any child, you have asked your CTVA surgeon to cannulate. But he told he's an adult surgeon and his pediatric exposure is not so optimal, but he can try for that. Then you call Dr. Puvoni and he is available in Mumbai. His flight is late. So he can spare his time and to reach your place within 4 hours and can assist you. Now, in between, the cardiac surgeon is in hurry to put ECMO early. So how we are going to go with the case? Puvoni sir, any?
Thanks, Arpan. My main intention in bringing up such a scenario is, as I was teaching yesterday as well, when you are planning to do ECMO, it has to be the team, that entire team has to be ready. It is not just that you had theoretical exposure to ECMO and start doing ECMOs as such. That is again our responsibility from ethical point of view. So the cannulation wise, yes, any of the local surgeons or anyone can do our intensivist can do the cannulation, but it is about our ability to understand the case and take the case forward as a team. If you don't have specialist nurses to run ECMO and those are to analyze ECMO and have it dealt with ECMO emergencies in the past, how to deal with them. So if the entire mechanism is not ready, just don't try, because you have a mission, don't try to put a patient on ECMO and carry on further. That is my main request to all the participants and to the entire medical population who want to do ECMO. Those are my few lines on it. Thank you.
I think this child can be managed on high frequency oscillation or something until the team comes. So he is a child, so we can still wait for that. We have other ways of management.
Or refer the patient to a place where ECMOs are being done on a regular basis, so he will have the right treatment. But it shouldn't be like you are just exposed to ECMO program and you want to run it. That's my main objective in conveying this case.
Kapil, any input?
Yes, sir. I think forget about the cannulations. Even there is a stalwarts who are there in the ESOI group. So after completing this course, you can get entry in that WhatsApp group also. So whenever you start, definitely at the first case you will get a difficulty, because this is the scenario. But in real situations, whenever you will start the ECMO program in your institute, it will be a first case. As far as the surgeon is concerned for the cannulations, or for sake of you also going to be first time exposed for it. So whenever you are in dilemma, and it is not related to ECMO, any times for the new any modalities of treatment which is going to be helpful for the patients, always be free to take an opinion of your colleagues or the experts or the whosoever has the experience about it. So this is not an experience-based medicines for you only, but whosoever has done already in the past, you can take share the case with them, you can take views from them, and first aim in the medicine is just don't do harm. So take opinions and don't stick to your ego or anything. So it is always better to open for all takes and views and opinion. Even during ECMO runs, after few days of ECMO runs, if you get some difficulties, you can ask and raise the questions. So always there are ways to look at it, and if you'll find a good way out of it. And it is always an interest of benefit to our patients.
Vivek sir.
Yes, I fully agree.
Do you think that all of us do pediatric and adult both? So do you think some kind of thin line is going to come with this adult and people not doing pediatrics, or pediatrics people not doing adult, this kind of things?
Yes, definitely, because as the specialty is growing, there will be subspecialties, sub-subspecialties, so it is going to happen that there will be a demarcation line. Because definitely kids, small children are not a similar adult. They have the different physiology. If we look at the neonates, they have the different physiology. Small child will have a different physiology, different challenges. So definitely it is going to be solely a subspecialty, that adult, pediatric and neonatal, possibly. Not now, but probably in future. Adult and pediatric can be clubbed, but neonatal will be definitely a separated specialty. I think Dr. Pupuni sir will agree with me on this. And moreover, a few things I would like to say. The wonderful discussion was going on. Please remember, never use ECMO for prolonging the death. This is probably the crux of the previous case discussion, that you just don't continue ECMO for prolonging death. You should be, as an ECMO physician, you should be very, very clear that which patient is going to make out, which patient is not going to, possibly not going to make out, and you should be clear during the counseling as well. Because family looks at a small movement of the hand of a patient and will be very happy that a patient has moved the hand. Probably tomorrow he'll move the head also. Day after tomorrow will open the eyes also. But you, as a clinician, you should be very clear, as we do for routinely for other ICU patient. Probably a more thoughtful, more precise in the counseling and discussion should be. In this particular case, it's not only the cannulation, but I think every aspect of the care, if we are in doubt, there should not be any hesitation in asking others, taking others' opinion, or putting in the group that what can be the possible um, management for this particular issues. This is important. And cannulation probably is one of the most important aspect. So the cannulation should be done by a person who is the most trained, most experienced, because we are dealing in a very critical situation when a patient is, and if there is a cannulation failure, there will be ECMO failure. That we should always keep in mind. So no egos. Who is doing? Surgeon is doing, intensivist is doing, pediatrician is doing, anesthetist is doing, doesn't matter. But what is the most important is the outcome, that you are doing a cannulation without complication.
Arpan, adding on to what Kapil has said earlier, yes, everyone will have their first case at some part of their life. But as in Western countries we go by, and also in our ECMO fellowship program, as it is a must for people to go through the preceptorship, be in the ECMO program, see what is happening, be part of it for some time. That is the time to go and have your first case, provided your team is ready. It is not you alone, but your team has to be ready. So that would be the situation to take up your first case with the team being ready. And you had some experience, prior experience, but not simply after attending a theory or simulation course. Thank you.
I think in our ASOI course, that 15 days of mandatory, you have to go at the bedside with any center. That is very much helpful for the fellows who are doing these things, because that is actually strengthening their ideas of putting ECMO, the continuation of ECMO, the cannulations, the decannulations, everything they are watching, and probably that is going to help a lot to start their first case or to continue their program. So not only a course, but it is also some ECMO watcher program kind of thing would be of helpful if you are really keen to start the program in your institute. So thanking all of you. I just could not touch the organ donation on ECMO, the ethical considerations. So we'll make it later on. Few things, we have a lot of ECMO helped our fraternity well, and this is the lady actually who came out of 81 days of heavy ECMO with one single oxygenator, and she's this one. And thank you all of you for joining this wonderful discussion. Any questions from the audience is I'm happy to answer.
Any of you have any question? Come on, it must have faced some dilemmas that can come out with it. Arpan, one from the next ethics, you can add one topic on ECPR. A lot of dilemmas and ethical issues are there.
Sure, sure.
In the last scenario, why don't we consider central ECMOs?
Central ECMO for
The small baby with less experienced CTV surgeon.
6-year child, you can
with the RDS.
With ARDS, the patient can go for a venovenous ECMO.
But
Central ECMO should not be taken very easily. With my discussions yesterday, as I was saying, post-cardiac cases where the chest is already opened or in severe vasodilatory shock, outcome is abysmal in those cases also. Those are the two instances you tend to go for central ECMO. Apart from that, peripheral ECMO is much more easy compared to going on to central cannulation. The amount of blood loss in central cannulation will be a lot, and it will be difficult to control also. Continuous oozing will be happening in those cases. Infection in our setup is horrible, and that can set in early. If it leads to mediastinitis, you are inviting another additional problem. So in those cases where central ECMO is done or central cannulation is done for valid reasons, in those cases also beyond 72 hours, we tend to go for peripheral cannulation from central cannulation because of these two complications which are almost likely to happen: mediastinitis as well as kind of severe oozing. Thank you.
In the second scenario, we discussed about a patient who is in severe respiratory acidosis and impending cardiac arrest with fixed dilated pupils. And our panel opined about straight ahead we can go for VV ECMO and systemic heparinization without scanning the brain. What if we later on found out this patient is having a massive IC bleed and he is already kept on heparin? How can we explain this to the family?
That's a very pertinent question that you have raised. Not just about the fixed and dilated pupils.
It could have maybe happened due
to the intracranial hemorrhage in a high PCO2 situation can occur pre-ECMO, can occur post-ECMO. Even when you have put the patient on ECMO, and if you rapidly come down on the PCO2, there is a very, very high chance of a bad neurological outcome in those patients. So we are very, very careful while putting the patients on ECMO with a very high PCO2, so that we can gradually, very gradually come down on the PCO2, not rapid correction of PCO2. That is not recommended. And your systemic heparinization has to be minimal in the initial few days till your PCO2 is come down or you have seen the patient waking up.
And moreover, can I add something?
Yeah, sir.
Yeah. So what Dr. Deepanjan said rightly, moreover, when I was answering this question, the first thing I said, the patient's relatives should be counseled and an appropriate consent should be taken. So the counseling should include the same thing, what question you are asking, that there is a possibility that tomorrow this patient may not wake up because of the intracranial hemorrhage or because of the impact of a cardiac arrest, because hypoxic brain injury is quite common, and that is a possibility, though less chances with these patients. What we have seen in our clinical practice, for a short span of CPR even patient recover very well. So still there is a possibility, and that should be counseled thoroughly, and if possible all these consents should be done under video, so you have a recording for all these details what you have given during counseling to the relative. And same thing to be maintained on the consent itself, and in fact we have a very descriptive consent when we take for ECMO, that these are the possibility, because during ECMO run, as Deepanjan rightly said, that when you reduce the carbon dioxide rapidly, there is a risk of ICH. Even patients is on heparin, there is a more risk of ICH. All these can happen. But yes, if in next 24 to 48 hours, when a patient start responding, you are clear that no ICH has happened. Once you have placed a patient on ECMO and no response after 24 hours, now you can do imaging. Doing a CT scan will be a good option here to evaluate that there is no ICH. So you'll be sure that no ICH, or even after 24 hours, you'll get some changes in the brain if there is some hypoxic injury as well. So all these can be explained to the relative.
So coming to this context, again, I would also like to mention that in the past I've seen a patient where the post CPR, because of adrenaline and maybe probably atropine and all, the pupils were dilated and everyone was reluctant to put on ECMO. And the patient was on ECMO, and then later gradually the pupils, after few hours, it took long time, it took maybe like 4 to 6 hours, maybe more than 4 hours definitely, for the pupils to react. So it's just the pupillary reaction post CPR and all due to so many drugs and all. We cannot just go by that and say that pupils are not reacting and then everything is bad.
And
So we have to take some time and then evaluate later.
It is benefit versus risk. In these cases, practically taking this patient for CT scan evaluation of the brain would be difficult. And similar situation happens in ECPR cases also. You have to presume that the child will be supported on ECMO and take the patient on ECMO. We will never subject any of our ECPR patients to CT scan brain before putting them on ECMO.
Correct, yeah. Thank you.
My question is on 50-year-old gentleman with 120 days on ECMO. What is your take on palliative care in these kind of patients? Palliative or end of life?
So there is a growing understanding that palliative care has to come in the patients where you are getting a futility in these kind of patients where you have a futility. Some of the patients may go for a lung transplant, but most of them either they can't afford or they don't want to go for a lung transplant. So the role of palliative care increases very much, very much. Psychological counseling, palliative care, and also to the speaking with the relatives about the outcome that the patient might be having. So on one side, you are supporting the physiology. You have tried to cure the patient. The patient is not not improving. The lungs have permanent changes. Now what? Now it is just like any other, in a malignancy that you do not have any cure. What you have to do is you have to accept it and have a proper way of accepting it. The same way palliative care is coming up in a big way in prolonged ECMO runs where you know that it is going to be futile.
Just to add to this, what Deepanjan said, when we say palliative care, there can be two things: withdrawing of support or withholding the support. So withdrawal can never be a unilateral; it has to be bilateral, especially in the non-scarcity situation. That family has to be counseled. If family agreed for a withdrawal, you can think of doing withdrawal. That also you have to look for the law of the land, that Supreme Court does not allow us to do withdrawal in the straightforward by the decision of the doctors and the family itself. There should be a board from the hospital itself, and that should be approved by the medical board made by the district magistrate. And once it is approved, then definitely, yes, you can withdraw the support. Withholding the support, yes, up to a certain extent, you don't escalate the support. This you can do with the agreement of the family. And moreover, definitely you do counseling every day, and they are also seeing that this is happening. So you can very well correlate with this, and you can explain them that I think when we are not going for a transplant, then probably adding to this treatment will not be of a good choice. Okay, you don't want, because the family will have a feeling if you withdraw the support that we have killed with our own decisions. So many times it happens, we see as a critical care specialist. So in those situations, definitely you can counsel them, don't escalate it. Wherever he is, just hold it. We will not withdraw it. We'll allow him to go. So this all become a part of the palliation. But yes, the patient comfort and patient should be on the topmost priority. That patient should not have a pain, patient should not be in the distress, and should be a comfort. It's like a comfort care what we do in the palliative.
Sir, my question is, how long can we continue the ECMO? Suppose if the child is not having any fibrosis changes on the CT chest, so how long can we be continuing? Because there will be some situations where we will be continuing the ECMO for around 2 to 3 months, and the family will be running out of the finances despite the crowdfunding and pharmacy investigations, everything. So if the parents are forcing us to withdraw the support, how do we counsel them, and how long can we be continuing them? If everything, the oxygenator pump, everything looks fine, so how long can we continue, and how to counsel them regarding the non-withdrawal of the support if the child is static, not worsening?
It will be a bilateral decision. It cannot be unilateral decision at any point of time. If the family is telling no, we don't want to continue, you cannot. You cannot do it for unlimited time. You have to tell the family targets that if this happens, then probably we can withdraw. This does not happen, then we can withdraw. Because you cannot say patient is static, we want to continue ECMO and you will continue it. This is not possible because it is not only a financial reason. There may be so many other things ongoing which can be contributing to it, that the family has taken a decision on withdrawal. So appropriate counseling, understanding the reasoning that why family wants to withdraw the support, and keeping in mind that there is a static situation where we are in a situation where ECMO with the nowhere, that we can't reach anywhere, then possibly that will be a situation when we have to respect the family wish and we have to withdraw. As a clinician, we cannot take an independent decision that no, you want to discontinue, but I want to continue. We cannot do that for unlimited time. 1 or 2 days, if you feel that in next 48 hours you are going to remove the ECMO support and you feel that there is a good recovery of the child or patient, definitely you can counsel the family. If one member is not understanding, you ask some other member. Sometimes you need to talk to their physician, family physicians, that to make them understand in the clinical language that this is what is happening and we are expecting that in the next 48 hours we will be able to remove the ECMO. So all these should be taken in consideration, but it cannot be unlimited. So you have to have a target.
So usually the child's lungs have the good healing capacity. So how long can we be waiting, sir, till the chest
See,
recovers?
if everything is fine, then probably a longer time, if everything permits. Because if there is no second organ damage, lung is not yet fibrosed, you have to look for a cause that why it is not healing further, why it is not improving. But yes, you can continue if the family is willing to do so.
It depends on your expectation also. As I was mentioning yesterday, you don't expect the lung to be 100% clear by the time it comes off. So are you missing any windows of opportunity to come off, bypass? If you ignore them, if you don't realize them, and if you ignore them, that may be one reason why you are continuing an ECMO electively. But taking the experience from the West, there are cases where children with a single organ failure, even adults with single organ failure, are continued on ECMO for months together for more than a year. One of the examples is about tuberculosis, for example. So the duration is immaterial. In wealthy countries, they have options to go for some other modality, but we can't in our country. We have to continue on ECMO and see, as Vivek said, if there is no other organ involvement, if it is single organ involvement, you have to continue, look for opportunities to come off ECMO in between and come off. That would be my say on this.
I think meanwhile investigating for syndromes, genetic related issues, like suppose the baby is there, like capillary alveolar dysplasia, everything will be fine, but you cannot wean them off. Like that, there are some things which you can keep investigating in between, and then if you find something which is not compatible with withdrawal, like not supporting the withdrawal, the life or something, you can, that becomes easy for you to counsel. Yeah, otherwise we have to definitely respect their decision also. Otherwise, especially in corporate hospitals, if you prolong too much and ultimately they'll end up in some sepsis or something and they die, then all the blame you have to take. So that is a very big challenge.
Thank you, sir. Thank you very much. Bhuvani sir, thank you.
Thank you, everyone.
Thank you.
Thank you, Vivek.